So cortisone is still, unfortunately, from a medical perspective, probably first-line management. The LEAP trial, I think, fairly clearly shows that education and exercise should be first-line management. So if we can avoid cortisone, first up, I would rather, as I said before, if I've got someone limping, I'd rather put them on a walking aid for a short period rather than send them for that cortisone injection. Because there's a couple of things that cortisone does that might be negative for our outcomes. And one of those is that cortisone is toxic to our tendon cells, and it might influence the way our tendon then responds to subsequent loading. Second, and let me just qualify that, even if the cortisone is going into the bursa, it is still affecting the tendons. So a lot of physios will ask me, but the injection is just into the bursa. So is that a problem? Well, yes. It used to be a lot bigger problem when it used to go into the tendon, because that significantly increased the risk of tendon rupture. They shouldn't be putting a cortisone injection into a tendon anymore because of those high risks of rupture. But they put it around the tendon. And so that is generally into the bursa, but it will affect the tendon as well. And so we have those toxic effects on all of those soft tissues there. But the other thing we have is a behavioral effect. And so because cortisone does take that pain, and usually it's accompanied with local anesthetic, which is also toxic to tendon cells. And so those things together will tend to give a very rapid pain relief, reduction in pain within, straight away. And so you have patients that, because that pain's gone, they may not, even if they then have physio straight away or at the same time, they may not adequately attend to or place value on load management strategies and exercise therapy. And sometimes it's just that, pain is a good reminder. If you don't have a little bit of pain there to remind you when you're walking up those stairs, you get that pain, you go, oh, that's right, the physio told me, take my feet further apart. Oh, yeah, that's better. It's a very powerful learning tool. Pain is very powerful there. But if that's gone, they're not going to learn that lesson. And so they're not going to sort of remember, oh, yeah, okay, we should, walk in this way or change the things that I'm doing. And also, we know that patients' lives are busy. All our lives are busy. And so if your pain's under control, then are you going to go and do that exercise program, or actually, I need to do X, Y, or Z? So it's sort of about priorities. And it is interesting, like with the LEAP trial, so we had the three groups, so the education and exercise group, the group who had a cortisone injection, and a wait and see group. Now, the corticosteroid group and the wait and see group both got a basic pamphlet, information pamphlet, that told them a little bit about the condition, and it gave them some simple advice, which was around, so if you're getting pain with walking, just reduce your walking for a little while, let the tendon calm, and then gradually build up, avoiding, sharp peaks in loading. So that was all the advice they got. But both of those, the cortisone group and the wait and see group, both got that advice. The education and exercise group, of course, got that advice, but a lot more detail. But interestingly, we tracked their activity levels. Now, let me say there wasn't statistical significance between the groups, but the pattern we see is what I tend to see in clinical practice as well. So the education and exercise group and the wait and see group both reduced their activity levels for the first few weeks, for the first 4 weeks. Then they slowly increased over time and gradually increased over that 12 months. The corticosteroid group, they actually increased their activity in the first 4 weeks, and then they crashed. Their activity levels dropped right down, and then they stayed lower. Now, again, not statistically significant, but it's that sort of pattern, that behavioural pattern that we see, that if the pain's gone, then I go, right, oh, well, I can still keep walking. I can still keep doing, what I do. And so I think that then, puts us behind the eight ball with our management program. And then when the pain comes back, because it usually will come back, particularly if you start increasing your activity levels again, there seems to be a higher likelihood that the patient will seek out further injection, further passive intervention. And that's human nature, isn't it? If you've had something that has helped, you'll want to have more of that thing that is helped. But we know with multiple injections, that's going to have a more potentially adverse impact on tendon health and potentially on outcomes longer term as well.